Good morning. This is Dr. Rutledge, and we've been doing a series on the technical details and the performance of the mini-gastric bypass. And we've been going into such great detail that I've had some requests to give more of an overview to introduce the more detailed tapes. And so what we're going to do this morning is discuss the mini-gastric bypass, emphasize that there's a lot more information, and this is not an encouragement to use the operation, but just for those surgeons who are considering it and want to think about it, even hypothetically, we want to give an overview of the steps in the performance of the mini-gastric bypass. Remember, again, there's a variety of opportunities to see the actual procedure performed, both the intraoperative laparoscopic view as well as the view from externally, as far as the view into the operating room, to see the positioning of the patient, the positions of the surgeon, the assistants, the anesthesiologist, and things like that, so that you can get a view of those things. But this morning what we're going to do is focus in on kind of a abbreviated discussion of the steps in performing a mini-gastric bypass, mainly to emphasize that it's a simple, straightforward, and I would use the word, I think it's an elegant procedure. And it's a reminder of something called Occam's razor procedure. And it's a reminder of something called Occam's razor. Occam was a philosopher, and what he stated is you never use more than you need to do something, so that an explanation for cause of an event, always try and use the minimum possible. Same thing we think is appropriate for weight loss surgery. We want to use the kind of very minimum that we can, not in cutting corners, but minimum in that we want to have a smooth and elegant, almost like a dance. If you see a dancer who's really good, you see this kind of economy of motion. There's not a clumsiness, a clunkiness to it, but a smoothness to it. And that's one of the things about the mini-gastric bypass, is it's conducive to a kind of a step-by-step, a very smooth process. And so we'd like to talk a little bit about that. And so again, we're going to begin imagining that we're in the operating room. We've done our checklist to identify the patient and go through the other parts of a checklist, and the patient is now, as we say, prepped and draped, and we think table positioning is very, very important. We want the surgeon standing at ease, straight up and down, arms at his sides, and elbows bent approximately 90 degrees, and wrists at a comfortable position. We don't want the arms out or up. We don't want the wrists flexed or extended. We want them kind of at the neutral positions. And we ideally would like to be using our fingertips, not our shoulders, elbows, or wrists, to do the motions. And so to let this happen, since obviously the surgeon is standing vertically, the patient is lying horizontally, we want to tilt the patient and bring the patient up towards the surgeon. And we see many new MGB surgeons have trouble with this or not pay attention to this, and they're really missing out, in my opinion. So maximum reverse Trendelenburg, that's the whole bed remains flat but tilted, so the head goes up to the maximum in which the bed will go, and then we tilt the left side up, the maximum it will go, which is usually 30 to 45 degrees. And basically this is like bringing the patient up to meet you, the surgeon. Then we place our ports, and there are 5 ports. The first port is the lower midline port, and that's placed about 1.5 palm breadths below the xiphoid sternum. And we don't pay attention to the place of the umbilicus on the patient, but the key guideline here is the xiphoid and that usually works pretty well. Not always, but usually. Then we're going to place 4 other ports that are all going to be about 2 finger breadths below the costal margin. So again, the costal margin is a pretty good landmark, we found, and we're going to place the ports in the right and left anterior axillary lines, the midline, and the left mid-epigastric line. And so as surgeons you'll know these locations, but a 5 millimeter port in the left anterior axillary line, and then 12 millimeter ports in the mid-epigastric, midline, and right anterior axillary lines. Once we get in, obviously we look around and explore, and what we're going to do now is we're going to put a grasper in the left hand into the midline upper port, the upper midline port, And then we're going to put the harmonic scalpel in the right hand through the mid-epigastric port on the left, and these are going to be your two working ports. Left hand, upper midline. Right hand is going to be in the mid-epigastric port on the patient's left side. As your assistant and scrub tech, will have that person hold a grasper through the 5mm port in the left anterior axillary line. You'll pay your attention then right to the lesser curvature of the stomach and the crow's foot. The left hand lifts up the liver a little bit if necessary, and the grasper from the assistant coming through the left anterior axillary line port grasps the body of the stomach and the antrum and pulls it down towards the left lower quadrant of the patient. And then we go ahead and use the harmonic scalpel to skeletonize the lesser curvature. We go into more detail about this elsewhere, but you really want to skeletonize that. You want to avoid going up, that is towards the head, that is proximal towards the EG junction, and instead head distally for the majority of your dissection. You'll have less bleeding, and that's a good way to go. That usually takes about 5 minutes. Then the grasper is removed, the harmonic scalpel is removed, the grasper is placed through the mid-epigastric port in the right hand, and the stapler is placed through the midline upper port. You are two companies, and I won't go into all the details about firing, but it's critical not to have bleeding, and the skeletonization and how you use the staple gun can make a big difference here. So the staple gun goes in, we apply it so that the angle comes from the upper midline port down towards the left lower quadrant at the junction of the body and the antrum where the crow's foot is, between the vertical and horizontal stomach, between the body and the antrum. And it's applied here pointing down to get a large, long gastric pouch. We want that long gastric pouch, we want the long, narrow gastric pouch, because that's what a Billroth-2 type connection is dependent upon. If instead the staple gun with different port placement were to come in from below, which I see in some videos of other surgeons doing the mini-gastric bypass, you're going to get the potential of a narrowed tip, kind of a bird's beak effect, and that shortens your pouch by 3 to 5 centimeters, and that really can interfere with the results after the mini-gastric bypass. So it's, in my opinion, a really critical point. Come in from above, pointing down. Wait anywhere from 1 to 5 minutes, depending on the bleeding situation with your patient. Go ahead and fire that staple gun, and then take the staple gun out, and either repeat through that port or change the grasper to the midline port and the staple gun through the mid-epigastric port. And now, running parallel to the long axis of the patient, you put your staple gun in and repeatedly fire the staple gun up towards the EG junction. Now, some surgeons will dissect the EG junction, and I'm strongly opposed to that. Instead, what we like to do is fire until you've almost completely divided the stomach. Then the left-sided grasper from your assistant pulls up the bypass portion of the stomach and retracts it up and towards the patient's left shoulder. And the left hand of the surgeon lifts the pouch and lifts it anteriorly and medially. And this will display the posterior attachments of the stomach and the greater curvature to the spleen and near the EG junction. And we recommend a meticulous dissection under direct vision here, being very mindful of the short gastrics in the EG junction. You want to take down any short gastrics. You can do a little bit of blunt dissection with the tip of the harmonic scalpel. If you see any obvious short gastrics or areas of concern, they can be divided hemostatically, and at that point then you should be able to dissect through into the free space underneath the left hemidiaphragm. The harmonic is removed, the final staple gun is applied, and with a mature, skilled team, that usually finishes at around 11 to 12 minutes. The harmonic, staple gun are removed, grasper stays in the left hand in the upper midline. The camera now rotates down to look into the patient's left gutter. Another grasper is placed back in the other working port, the mid-epigastric port, and we retract the omentum medially. In my 6,000 cases, you do not ever have to split the omentum, and we believe that's a time-consuming, unwise, potentially maybe set up for bowel obstruction type situation. So we strongly oppose it and recommend just retracting medially and work over to find the ligament of Treitz. Once you find the ligament of Treitz, you run the bowel in a hand-over-hand fashion, and what we found is the normal hand-over-hand motion that I use results in a movement of about 1.2 inches per movement, so that makes about 10 movements per foot, and so we go about 2 meters or 6 feet, so that's a count of 60 hand-over-hand motions. At that point, that loop is identified, a grasper is placed in the left anterior axillary line port, the loop is clamped, and then attention is turned back to the gastric pouch. At this point, the right hand grasper is removed from the mid-epigastric port, the harmonic is placed, and we make a gastrotomy with the harmonic scalpel. Now there's a little trick here, which again I think surgeons need to pay attention to because I think it's very valuable. You take the camera out of the camera port, which is the lower midline port, and move it to the right anterior axillary line port so it's perpendicular to the long axis of the patient. And you're aiming now to look over at that loop. You're looking at the loop across the body of the patient, from the right side to the left side. And the reason is because you want to use that lower midline port for your staple gun. But first, you put in the harmonic scalpel, you pick up the loop with the left hand through the upper midline port, and then with the harmonic scalpel make a small anerotomy. Then the right hand takes the harmonic out, the staple gun goes in, you dilate the anerotomy with the anvil of the staple gun, take the anvil out, put the cartridge in, release the grip of the other grasper, and the normal downward pull of the mesentery of the small bowel will drape the bowel now over the tip of the staple gun. And this is very convenient because now you can use your right hand to manipulate that bowel. It won't slide off and you won't have any difficulty or fumbling. Now you rotate the camera back towards the gastric pouch and its tip. You open the gastrotomy with the 2 graspers, hold that firmly, and then advance the anvil of the staple gun in while retracting the bougie tube. And here we're going to do a linear stapler and form your gastrojejunostomy. Again, don't be in a rush. Take your time with this. This allows good hemostasis. Following this, the staple gun comes out. You take a look at your gastrojejunostomy, and then we're going to complete the surgery by grasping the lateral corner of the defect left behind by the staple gun and the anerotomy and gastrotomy. We're going to use the left hand to put the bowel into the jaws of the grasper along with the stomach in the middle of it, and then the medial corner is lifted up. So basically, for surgeons who've done this, you know if you do a right hemicolectomy and an ilio-ascending colostomy, you know that when you do that, you do a stapled anastomosis, and then routinely, many surgeons, maybe even most surgeons, close it with a TA55. So that's what we're going to do now, is close that defect just like you would with a transverse closure of an ilio-ascending colostomy with a TA55. So we're lifting up the lateral corner, the middle portion, and the medial corner with 3 graspers, and then from the lateral port, the right anterior axillary line port, we bring our staple gun in, and take your time to, this is a very critical firing, and we fire a staple gun once, and if you're using a 45, you might need a second time, or even a 60, you might need 2 applications. And now the excess tissue is removed, the anastomosis is explored and evaluated, and if all looks good, the surgery is complete. And the average operating time for me to do this is about 39 minutes. Now let's go through it again. Port placement, skeletonized lesser curvature, staple perpendicular to the lesser curvature, change the angle of the staple gun and run parallel to the lesser curvature adjacent to the bougie or tube that you use to size the pouch. Go up to the EG junction. As you get close, then under direct vision, very carefully dissect that area, staying well away from the EG junction, carefully identifying and dividing under a cautery, harmonic scalpel, or ligature, the short gastrics. Finish that firing. Then you turn your attention to the left gutter, retract the omentum medially, identify the ligament of Trice, and run the bowel for about 2 meters. Longer for heavier patients, shorter for lighter patients. Then grasp that loop in a locking grasper, do a gastrotomy, change the camera to the right anterior axillary line, go ahead and put the harmonic in, do an anerotomy, take the harmonic out, do the put put the staple gun in the small bowel and then do your gastrojejunostomy. Lift up the stomach and bowel and complete the closure with a stapled closure of your gastrojejunostomy, and that's your surgery. Simple, elegant, operative times really rival some of the shortest surgeries that are done in major ORs today. Very simple, very effective, very low leak rates, and easy to manage leaks and when they occur. So this is Dr. Rutledge. I hope that was useful, and there'll be more details on each of these steps in some of the later videos. I hope you can check in and follow that. Thank you very much.